So I missed a birthday party last night, and as I was explaining to my grandson why I couldn't attend, he said, well, what are you going to do? And I said, well, I'm going to a room with a lot of other people, and I'm going to look at cartoons all day. And he said, okay, why do you get to do that and I don't? So for that reason, I will have no slides. He shamed me. So let me talk to you today a little bit about two very well-intended policies that I think are actually impeding access to these kinds of cancer therapies that Dr. June was just talking about. You can't sit in this conference today without being excited about the future. The potential is immense. But if we can't afford those therapies, they don't mean anything. And when I looked at the data at my former position as a national carrier, when somebody's on active therapy for cancer over their lifetime, 50% of their costs are drugs. So I want to talk about drugs today. There are, I think, two policies that are actually causing harm, even though they were originated with good intentions. And the first of those is a mandate. For all the federal payer programs and for commercial insurance in 42 different states, there is legislation that says if the drug has been approved by the FDA for cancer, it must be covered, period. Okay? You don't get to look at efficacy. You don't get to look at the cost. You don't get to look at whether or not there are competitors in the space. And you saw the inflection today about where somewhere in the 1990 to 95 range prices started to rise. I would argue that that's a direct reflection of those mandates, that manufacturers know that there is no negotiating when they put a price on the table. And so they have been testing the upper limits of how far we can go. I'll give you just a piece of evidence around that. This morning, Lori showed us a slide of a patient with lung cancer who had an ALK mutation and who was started on a drug called crizotinib about 7 years ago and still is in complete remission. These drugs are very effective. Crizotinib, when it came out, when that patient first started, cost about $11,000 a month. Now, since that time, there have been multiple ALK inhibitors or competitors to that drug placed into the market. Okay? If you go to the NCCN guidelines and look up ALK mutation cancers, they will give you 4 options of drugs that they believe are all equally as effective. And those 4 options I just priced a couple of days ago on the internet at what a patient would pay to get access to those drugs in Minneapolis. And here are the results. Ceritinib would be $15,000 per month. Alectinib would be $14,300 per month. Brigatinib would be $20,000 per month. And crizotinib, which used to be $11,000 when it came out, is now $16,000 per month. So competition in this space actually increases prices, and that makes most economists scratch their head. Why would that happen? Because it's protected. And I think we've got to, if we're going to be effective here, I think we need to introduce competition into the space. So rather than have a mandate for every single drug, perhaps we modify that mandate that insurers must have every class of drug represented, that patients do not get denied an important therapy. But we've got to change something to introduce competition into this space so that the payer can start competing now on your overall performance, and if it's the same, now start competing on your price. And I think we would see a major reduction in expenses. It's not the absolute price if value is there. I didn't hear anybody balking when the ALL CAR-Ts came out. Actually, they got paid relatively quickly, except by the federal government. But we need competition to bring those prices down. The second issue that's causing pricing problems is antitrust. Healthcare providers in the United States, for a lot of good reasons, have started to consolidate. And now we're at a point where Dr. Avik Roy, who's out of Austin, in the think tank environment there, has said that 85% of all of our major metropolitan areas are now dominated by either a monopoly healthcare system or a duopoly healthcare system. 85% of our markets, which means no competition. And how that shows up, again, is data I'll give you from United Healthcare that we have published. If we contract with a physician who is in private practice, an oncologist, we will pay, on average, 28% above the price of that drug, the wholesale price, as profit margin to that physician in our contract negotiations. However, if that physician is employed by a hospital system, we have to pay on average 156% profit margin. We pay for the drug 1.5 times again over the already very high price. And that's simply a distorted marketplace. 55% of oncologists now work as employees for hospital systems. When a payer walks into that hospital system and they say, well, here's our markup, we're going to charge you, name your number, 200% more, the payer says, that sounds awfully high. I get it for 28% if there's a medical oncologist in town, and you get two responses. Well, first of all, we've bought them all, so they work for us. Second response, if you don't want to pay that, then we won't give you access to our hospital beds, and you don't have any other options for those either. That's what happens in monopolies. People have that kind of leverage. So two potential solutions exist. One is to break up the monopolies. We have the FTC doing that on a regular basis, but healthcare has been protected during the last 2 decades, and cancer patients are paying the price. The other option is if a monopoly exists, rather than break up a healthcare system that spent a lot of time trying to put that together, just make them pay CMS rates for cancer drugs. Hospital administrators are going to balk at that because they say, we take the profits from that part of our system. The cancer centers are quite profitable, and we use that to support non-profitable portions of the rest of the healthcare system. A reasonable argument, but I don't think it flies with me to ask a cancer patient who didn't have any influence on getting his diagnosis or her diagnosis to support a healthcare system that's broken. Why are we overcharging her to fix somebody else's problem? It's not good. So we've got some real opportunities with free market solutions to begin bringing those costs down. Innovators will still win. A remarkable drug will still be able to command a very high price because they won't have competitors yet, and they'll do it well. But they also have the incentive to learn to bring that drug to market at a reasonable price. So they're doable, but they're hard. They're change. And a lot of us will be fearful about that. I am more fearful about the loss of access that might occur if we don't change.